Hello, and thank you for joining Antibiotic Stewardship in Production Animal Medicine, Regulations and Practice, featuring Dr. Mike Apley from Kansas State University College of Veterinary Medicine. My name is Nicole Cast, and I'm the Continuing Education Program Manager for the Minnesota Veterinary Medical Association. The MVMA is pleased to be one of the hosts of the Antibiotic Stewardship in Veterinary Medicine webinar series, along with the Minnesota One Health Antibiotic Stewardship Collaborative. We are also working in partnership with the Minnesota Board of Animal Health, the Minnesota Department of Health, and the University of Minnesota College of Veterinary Medicine. During today's webinar, the MVMA will provide technical assistance. If you have any questions during the sessions, please type them in the Q&A area. With that said, I'd like to turn over the session to our moderator, Dr. Amanda Bedoin, Director of One Health Antibiotic Stewardship at the Minnesota Department of Health.
Thank you, Nicole. Welcome to the Antibiotic Stewardship in Veterinary Medicine webinar series. My name is Amanda Bedoin, Director of One Health Antibiotic Stewardship at Minnesota Department of Health and Adjunct Assistant Professor at the University of Minnesota College of Veterinary Medicine. In my position, I work with professionals in human, animal, and environmental health to improve how we use antibiotics and to lessen their adverse impacts while effectively treating infections. The Minnesota One Health Antibiotic Stewardship Collaborative is made up of folks just like you, professionals interested in leading our state's multidisciplinary approach to stewardship. The collaborative has joined forces with MVMA to bring you a terrific lineup of webinars. The expectation to be good stewards of antibiotics is real and present. This webinar series is intended to provide background on the problem of antibiotic resistance, the solution to stewardship, and to provide actionable information for all sectors of veterinary medicine. This webinar, like the webinars that we've had over the last 2 months and the coming webinars in July and August, will be available archived online. Today we welcome Dr. Mike Apley from Kansas State University. Mike Apley is
Amanda, are you still there? We lost you.
Sorry, just a little bit of technical difficulty here. Sorry. Dr. Apley is a veterinarian with nearly 30 years of experience in food animal agriculture, including time as a general practitioner, a specialized production medicine practitioner and researcher, and most currently as an academic veterinarian focusing on the use of drugs in food animals. Dr. Apley holds the E.J. Frick Professorship in Veterinary Medicine at Kansas State University College of Veterinary Medicine. He was board certified by the American College of Veterinary Clinical Pharmacology and has an extensive background in the use of antimicrobials in food animals, including service-related task force and committees within the American Veterinary Medical Association, the American Association of Bovine Practitioners, the National Pork Board, National Cattlemen's Beef Association, and the Academy of Veterinary Consultants. Thank you very much for presenting today, Dr. Apley.
Thank you, Amanda, and welcome everyone. So you always wonder about where to range and how deep to go where in one of these, so I hope everyone finds something useful out of today. And I look at antibiotic stewardship after working with veterinarians and producers and consumers and retailers over the years is best served by taking a somewhat high-level view, and we'll drop down a couple times. So first, I want to put what we're talking about in perspective very quickly, and that's to bring us into where we are in the antimicrobial timeline. And in 1910, our options for a resistant bacterial infection would have been arsphenamine out of Paul Ehrlich's lab, which was the first product of high-throughput screening and was an arsenical. Then we're all well aware of the sulfonylamides, the sulfas, and then benzoyl penicillin's first use in 42. Then we went through a rapid progression of finding new antimicrobial groups, and these are the first member of that group produced. And you can tell that by 1985, we had experienced just a bloom of new antimicrobial groups. And then we got a couple more, the oxazolidinones in 2000 and the lipopeptides, cyclic lipopeptides in 2003. And of course, we've had a lot more members added to these groups with a lot of really innovative and novel chemical synthesis approaches. But when we start talking about food animals, the last time we got a new group that we use in food animals today was 1978, so 41 years ago, when we got the first of the fluoroquinolones released for human use. It makes you stop and think when we're 41 years post the last new group, and it brings to mind that we really have the majority of the tools we're going to have for food animal use. And stewardship thinking from a One Health perspective, that thinking is often dominated by potential effects on human resistance, the ability to treat infections in humans. But as a food animal veterinarian, I'm also very focused on our ability to treat our own patients. So I offered you that worldview, looking at the world from above, from afar. But the other thing that really has dawned on me, especially over the last 4 years of having the opportunity to participate on the Presidential Advisory Council for Combating Antibiotic-Resistant Bacteria, and I'll have a little information on that at the end, is that there is an incredible amount of worldviews, and all of our views are dominated by our own view. And so, for example, the astronauts looking at space that day that I pulled this up, they took this picture. After breakfast, before going to work, I looked out my back window, and that was my worldview. So that's a nice fall day. That was my view of the Earth. And so it just illustrates that we tend to be pretty local in our views. We can be educated and be aware of the overall picture, but as a veterinarian or a physician, someone dealing with patients, eventually it comes down, and in the case of veterinary medicine, that client and that patient dominates our thinking. So let's take a shot at that real quick. Let's start with our hemisphere. Let's zoom down to the United States, and then let's look at the center of the United States, which happens to be Kansas, and actually has the geographic center of the United States. And then let's go down over there to the lower left, and let's zoom in on Pawnee County, Kansas, where I grew up. And now let's zoom down onto the small metropolis of Larned, Kansas, where I grew up. And this is the town of Larned. So let's think about where all antibiotics can enter this community. Who all has responsibility for the use of antibiotics and the exposure of antibiotics in this community? So there's the veterinary clinic that I grew up and wandered around while it was being built while I was 4 years old. I grew up with Dad there in that clinic, had the opportunity to go back there and practice with him for a while out of school. There's our dentist office. There's our critical access hospital with the doctor's office in it. There's our long-term care facility. There's our pharmacy. There's another doctor's office. We have a feedlot out southeast of town, and we have a large state hospital facility to the west. People from this community go for care to Great Bend, to Hayes, to Hutchinson, to Wichita, Kansas City. My dad made a trip to Mayo Clinic in Rochester, Minnesota. So antibiotics can come into this small community now of about 3,800 people in multiple ways. Now we're going to drill even further down to my personal experience and worldview as a veterinarian. And this was me right out of school in an exam room at that veterinary clinic in the upper left corner. And I'm working on this Welsh Corgi, which came in with autoimmune hemolytic anemia. And I am administering a transfusion, and we have immunosuppressed that dog. And this first round of therapy, it responded rather well. So I'm here with the dog, but there's also a client that I had interacted with, and we had hospitalized the dog, and we're now treating it. So in my interaction with that dog, in consideration of, since it's immunocompromised, to help with the AIHA, should I have it on antibiotics prophylactically? And I use this question to get conversations started with groups of veterinarians and get very different opinions on that. But the point of our talk today is looking up there top. Am I supposed to be considering the fact that I'm going to be putting antibiotics into a dog that then goes out into the community and mingles with its owners, and that I'm applying antibiotic selection pressure in the community. Am I supposed to think about the county? Am I supposed to think about the state of Kansas? Am I supposed to think about America? Am I supposed to think about the world? And should those enter into my decision on whether or not I, as a veterinarian, think that antibiotics should go into this dog? How much should those weigh? And if we think that maybe I'm not capable of making that decision on my own, should we have someone watching me? Should we be collecting my antibiotic use data and comparing those against the disease to see if I made a right decision? Or should I have to get permission before I put that antibiotic in that dog? And of course, there's many human hospitals which have these in place. And perhaps maybe we put a little bit of regulatory kick behind that, where I am prohibited from using certain drugs, or I have to get licensed to do it, which of course we're licensed professionals, health professionals. But those go in there, and the result is there a barrier between my judgment as a clinician and what I put into that animal that is erected thinking about all those other pieces of the puzzle? And this is the exact same conversation as is had on the physician side. And now let's change this up a little bit. I've used a dog, even though our talk today is about food animals, but now I'm going to change the background picture. Does that change how we're thinking? So now there's myself when I was in Iowa, at Iowa State, with a calf with respiratory disease. I've got the syringe in my hand, and I am going to make a decision on what I do with that animal. Now, how does that change our worldview of what regulatory and monitoring processes should be in place? And that's where we've had a real focus in veterinary medicine, is that we are really focusing in on that use in a food animal, and obviously the relationship in the food chain and the environment. It's very clear that there's also the same type of interaction with our companion animals that go home and cohabitate with their owners, our clients, and that what we put into those animals can result in effects on the bacterial population in that household, and basically a family member that we treat as part of that family. So those are going to start being considered on, I don't know if equal status is the term, but we're going to be looking at both very closely. And of course, this line, the existence of and in what form the records being kept and the regulatory environment, is what we're talking about today, in the context of a little bit of science thrown in there, which we don't want to forget. So what is stewardship? The AVMA came out just the first part of this year with their new definition. And it says that it's what actions we take to preserve the effectiveness and availability of antimicrobial drugs, responsible medical decision making, safeguarding animal, public, and environmental health. So there's the balance, that we're supposed to safeguard the health of our patients, the public, including our clients, and the environment, while making responsible medical decisions that incorporate the conservation of livestock resources, and hopefully following evidence-based medicine, which incorporates the best evidence, our clinical judgment, and the best interests of our clients and patients. This is from the Infectious Disease Society of America, and it's quite similar, except there's something different in that on the human side, one of the things I've discovered over the last few years is that infection prevention and judicious use of antimicrobials are tasked, it seems, to two different groups. That to such an extent that the IDSA does not include any reference to prevention of infectious disease in their definition of antimicrobial stewardship. To me, theirs really incorporates judicious use of antibiotics. And in veterinary medicine, of course, we are all of it. We're tasked with both prevention and therapy. So I instead of waiting till the end, I want to throw out a working definition of stewardship that ends up being fairly similar, I think, to some others. But the first and foremost thing a veterinarian is responsible for is for diagnosing what disease is present and establishing an accurate and functional case definition, both for our own use and also recognizing the fact that many treatments, but all for prevention, control, and acute treatment of disease or treatment of acute disease, are often administered by the owners or agents employed by the owners. So one of the things that food animal veterinarians are heavily involved in is training of both owners and also their employed primary caretakers to carry out protocols created to both diagnose and address disease by applying case definitions and then applying a protocol. We then enter a cycle in which we identify a disease that's giving us a challenge, and our first obligation is to identify a non-antibiotic alternative which will effectively prevent, control, or treat this disease challenge. And our job is to ask one, and this isn't a one-time deal. To ask that question, we have to do it repeatedly, and that's why we go to CE, we participate in listservs, we have constant conversations, talk to our colleagues in order to figure out if there are other options and how we would address it. Of course, vaccines, environments, nutrition, animal husbandry, all those things. Then, if we're not able to prevent the disease, and prevention may involve the use of antibiotics, but now we're needing to select an antibiotic which has been demonstrated to be safe and effective for the purpose of treating that disease or possibly controlling or preventing it. Then we need to assure use of that antibiotic is shown to be safe and effective. And we talk about whether or not veterinary client-patient relationships are actually in effect at a place or not. I think I can tell you if a VCPR is present or not by if asking the veterinarian how they know if the antibiotics are being used as directed. In my consulting days, we had electronic treatment records in the feedlots, and one of the main parts of our visits was to go back through selected treatment records, especially mortalities, and see how we were adhering to treatment guidelines, and then gain input, work on those, both the case definitions and the protocols together with the crew. Then we ask if that antibiotic intervention is still necessary, and that's not as simple as it may seem, especially for prevention and control. If no, stop, and if yes, we enter the cycle again. You really have to emphasize on this slide that the ability to institute and maintain this cycle of stewardship is very dependent on the relationship the veterinarian has with the producer. In some cases, consulting veterinarians become integral parts of the management team of a animal production operation and are responsible for not only the diagnostic programs, the antibiotic use programs, all of those, but also responsible for training crew members in those. So, for example, on our twice monthly visits, we spent time with the processing crew, we spent time with the doctor crew. I'd crawl on a horse and ride pins with the cowboy crew that was looking for ill animals that needed to be brought to the hospital. And the time was spent learning from them, hopefully teaching them. We'd have sessions with slides and go through lesions and the necropsy time where we would do necropsies on mortalities was a valuable teaching time. And often we'd have those responsible for treating the animals in there with us, helping us do the necropsies, surrounded by cowboys on their horses watching around the edge, and a very valuable teaching time. So stewardship is wrapped up in all that, and the more intimate the relationship between the veterinarian and the client related to these interactions and training, the more the veterinarian is able to have these types of interactions with them. So the AVMA had some core principles with their stewardship definition that I wanted to come back to. animal health and welfare is maintained by preventive and management strategies to prevent common diseases. And again, the veterinarian is part of a team there. It involves a nutritionist. I know people who are experts in environment. We have veterinarians who have become extremely well versed in airflow, cow comfort, and across all animal species, understanding the carrying capacity of facilities and working in those environments. For example, one of the things we know is little calves in environments in the winter, if we close it up trying to conserve heat too much and hamper the airflow, it can lead to respiratory problems. So there has to be the correct amount of airflow going through there. And our stewardship involves managing that environment way beyond just saying, oh, we've got pneumonia, let's use this antibiotic. And that is a nice illustration of the overall application of stewardship. In our evidence-based approach in making decisions to use antimicrobial drugs, that's where I come in as a clinical pharmacologist. I can take you to a spot in the highway between Maxville, Kansas and Larned, Kansas, where I made the final decision to go back and start my PhD and pursue board certification in clinical pharmacology as I drove back from a client who was having trouble with some high-risk calves, repeated trouble, and really interactions like that had stoked my interest in clinical pharmacology. So providing that evidence-based support in making those decisions related to pathogens, most common pathogens, diseases, is a major part of what we do. Using antimicrobials judiciously, sparingly, and with continued evaluations of the outcome. And one of our goals here at Kansas State is to make sure our students, and then through CE also, that everyone understands the limitations of clinical observation on truly evaluating the effect of the antimicrobial. There's spontaneous cures, there are ones that wouldn't have gotten better anyway, and then there's the difference the antibiotic makes. And we have to be very careful that we try to parse those things out and understand the difference between observation and prospective randomized masked clinical trials. It's not that we as veterinarians or physicians aren't great observers with a lot of experience, but I think the more experience we have, the more we realize that we have to carefully evaluate all the things that are involved in therapeutic outcome. So I wanted to talk a little bit about how antibiotic use monitoring fits into this thing, and I'm going to use this circle to illustrate a production system. And once that thing starts moving, we've got technology, feed, water, land as inputs. We've got fuel, we've got labor, we've got money, capital, and then we've got a base livestock production. So for example, for feedlots, we'd be bringing cattle in from cow-calf facilities or stock or grazing facilities. So these are all the inputs that come in, and we start that thing turning. And we quickly realize that there are two really key observable happenings, outcomes from that system, and that's efficiency and welfare. When you start asking about the definition of sustainability, there are a lot of different ones, but in the animal production systems, one of them has to be sufficient efficiency to stay in business so that we're in business next year. And then also we have to be very cognizant of animal welfare. Then let's talk about the food that comes out of those systems, also our interaction with the environment, and then the interaction of both of those with human health. And to me, that's a slide that illustrates the complexity of the system. And now, if we're going to talk about antibiotic use monitoring, we're going to take a small piece of the technology up there in the top, and we're going to try to measure its use in the system, understanding that that use has an effect on both efficiency and welfare within all the antimicrobial stewardship principles we just talked about, where we're also tasked with preventing the need to use them if possible. Then we're going to look at the effects on food and environment and the potential effects on human health of using that piece of technology in animal systems. And in Europe, they very heartily embrace the precautionary principle. It's discussed over here, and we run a balance between what can be documented for effects and precaution, understanding that limitation on that use can have an effect on both efficiency and welfare within the same system. And one of the things to understand about systems, especially very complex animal production systems, is if you choose to conserve one input, you're either going to have to increase another input or change the system, usually in such a manner that you decrease output. So to just restrict or take out antibiotics, we modify other things, maybe lose efficiency, or if other changes aren't made, can have an adverse effect on animal welfare. Those are all illustrate the fact that to just isolate out the effect of antibiotics on the disease leaves all these other things out there. So to just iterate one last time that there is another very important thing, the food generating income, which comes back for that input back into the system. So let's start monitoring. Let's monitor antibiotic resistance on food and monitor antibiotic use coming into the system. Now we've got two gauges, and we could have a long discussion about exactly where those are related, not related, how much evidence is there. I would opine that there are no isolated bacterial systems that I've heard of yet out there, and it's about magnitude. We also need to measure welfare in any of these systems, and whenever we discuss antibiotic-free, I'm always curious about what happens to animals that do contract pneumonia, do have foot rot, and what happens with them. Are they able to be treated and moved to another system? So I always want to include animal welfare in these, and I think that taking account of efficiency is also valid. And really, if we're really going to understand where antibiotics fit into these systems, we have to look at all the inputs, evaluate outputs, evaluate efficiency, welfare, and the use of antibiotics incorporated with those. Information on those relationships, and it's well within the power of consumers to make choices based on how they perceive the best uses are. We have regulatory input, there's legislative input, and of course, as veterinarians, we're tasked with interacting with the client to make sure that these are used in the best way possible. So we've talked about resistance now, and one of my favorite questions for people that use the R word is, what is resistance? What's your definition of resistance? And I come from that having served a couple of very fruitful and rewarding and educational terms on the CLSI Veterinary Antimicrobial Susceptibility Testing Subcommittee, and working with other clinical pharmacologists and microbiologists to set breakpoints. So I have a very clear definition of what resistance is, but I'm not sure everyone involved in the discussion does. So clinical resistance, based off clinical breakpoints, are where we think that an R means it's not going to work, and an S means we have a chance of the drug making the difference of which it's capable. And we live with number needed to treat a lot in cattle. We have quite a little data to help us get there. And the number needed to treat number is a great way of evaluating the effect of antibiotics for a specific disease in a specific population and a specific drug regimen being used. For example, across respiratory disease in our toughest types of cattle that have the biggest challenge, we expect the number needed to treat of 2. About every other animal we treat, we change its clinical outcome from being a continued morbid animal to being normal in appearance. And every 7th one we treat, we prevent a mortality. That's across about 30 different studies that did selected antibiotics against negative controls. So we have those data. We knew what they're going to do. And these breakpoints that help us decide if those are going to work or not are sponsor generated for those. Clinical outcomes coupled with pathogen susceptibility data, MIC distributions of wild type isolate collections, and then PK/PD modeling. And these breakpoints are then developed to help us decide if that antibiotic is going to have a different chance of making a difference. Now, there's also ECOFs, or epidemiological cutoffs, and those are deviation of susceptibility profiles from the original wild type distribution that was documented when the drug was first released. So it is a epidemiological value that allows us to say a population is changing. It may or may not be associated with loss of clinical efficacy, but it is associated with a move in the MIC distribution of those organisms. And to be clear, the MIC is not about killing the bacteria. It is about inhibiting visible growth in the lab for a period of 24 hours or 18 to 24 hours. And if you're going to use CLSI interpretive criteria, which I hope you do, they need to be done according to CLSI guidelines. But the MIC is an indicator. It is a laboratory-based determination of drug-bug interaction and does not necessarily represent the magnitude of interaction in the animal or the person, but it is a laboratory indicator which, when correlated through clinical breakpoints, can give us an indication of what's going to happen in the animal. So here's an example of what we'd call a monophasic population with an MIC distribution of 0.03 to 0.05. And this is a biphasic population where we have another population showing up to the right. And typically, as always in biology, not always, but typically these are associated with a resistance gene or genes. And one of the things that's done in a breakpoint to establish resistance is to look at the separation between that original wild type population to the left and over to the right, this resistant population. Some bacteria have constitutive resistance against an antibiotic. Others acquire it over time. For example, there's well over 1,200 tetracycline resistance genes now that have been identified. Of course, we have our classics like TED-R and TED-M, but there are over 1,200 that are identified in about 4 or 5 different mechanisms. So rather broad base of resistance out there. The common concept is prior to clinical use, we have the population over on the left, then we get a little bit of a move, and then more time passes, and after years of extensive use, we have that susceptible population, maybe one in the valley between, and then there is our high-level resistance to the right. And that is constant selection pressure. This is a stereotyped move that we see for some of them. And one of the questions is how long it takes for that to occur, and we'll come back to that in a minute. But R doesn't necessarily mean that there isn't an effective treatment for the infection. So, for example, when we're down to using systemic colistin for an infection in humans, this is a case of only an extremely toxic option remaining, and that's what R means in that case. Sometimes R may show up for our standard empiric therapy after initial therapy failed. And what this means in this case is that resistance to the standard empiric therapy ended up in us having a longer time of disease presence before we were able to intervene with an effective antibiotic. And oftentimes in veterinary medicine, both in food animal and in companion, the cost of the susceptibility testing up front makes it so that we will commonly use an upfront empiric therapy and may or may not collect a sample for susceptibility testing in case our empirical therapy doesn't work. But we think that's just a veterinary deal, but one of the major barriers to continued test development on the human side is also the ability of getting third-party insurers to compensate for running that test as opposed to just going ahead and starting an antimicrobial therapy. So that's one of the things we share between human and veterinary medicine in a One Health view, is that we all have challenges in being able to apply diagnostic tests because of costs. R may show up on an initial culture collected at the time of therapy initiation. For example, in veterinary medicine and companion animal, in the referral hospital, we get these chronic urinary tract infections or chronic dermal infections, and it's not uncommon to see some pretty angry pathogens in there. And in veterinary medicine, we often see that R when we submit a culture to see why an infection was refractive to therapy. And some infection locations are much more invasive to culture. For example, having to do a transtracheal wash or just the dollars limitation to be able to do it. And sometimes it's after a couple rounds of initial therapy and with a more aggressive second round, and we still aren't seeing resolution. It may have been the initial pathogen responsible for the infection, or it may be a subpopulation which has responded to the selection pressure during therapy. That can happen in an individual case, or it can occur in populations. So populations where there's been routine prophylactic treatment of foals for Rhodococcus equi and is stable with macrolides. You can see macrolide-resistant Rhodococcus equi. I'm going to show you some Mannheimia hemolytica here in a little bit. We can have this happen with Salmonella, E. coli, et cetera, in populations. And when it's in a long-term environmental site, we can have interactions between the environment and the animals, which may or may not be clear, but we do know that Salmonella can survive for long periods in the environment. Of course, we institute aggressive sanitation procedures for that. One of the classic Salmonella outbreaks in a feedlot documented years and years ago out of Washington State, they traced it back to using boluses in the hospital where they were treating cattle, and they would put the bolus applicator, the gun we call it, in a bucket full of water with some nalvasan in it, but the birds would roost over that, and they would end up defecating in that periodically between changes, and they cultured the outbreak Salmonella strain from that bucket, which would mean that it would be repeatedly rinsed in there, thinking that we were sanitizing that applicator, and in fact, we're probably spreading Salmonella with that one fomite. So I think I'm pretty sure of this. I know I'm pretty sure of this, is that antimicrobial resistance equals antimicrobial exposure and the bacterial population exposed. Sounds a little academic and a little obvious, but in fact, many of the times we are talking about antibiotic resistance, we're talking about an antibiotic and its use and maybe one or two indicator organisms. But the results of exposing a bacterial population to an antimicrobial often depend on the underlying resistance that's present in that population and available to be selected for. So I always bring people back to the concept that we need to consider both of these when we talk about antimicrobial resistance and our ability to look at bacterial populations with shotgun metagenomics, and we talk about microbiomes, and we talk about resistomes and how we place those in context is very, very important to the description of what is feeding into antimicrobial resistance. We know the antimicrobial exposure. We usually don't know the characteristics of the bacterial population we're exposing. We may with monitoring over time, but often we don't. But even with culture and susceptibility testing, we won't know what resistant subpopulations are present, especially at the start, and we may see what comes out later after some antimicrobial exposure, but I don't know if we ever have as clear a picture as we'd like. So there's some equations that I think describe what we're doing, is that total use equals effective use and ineffective use. If we agree that there's some ineffective use out there, and that could be because it's perceived as effective, and without negative controls, we often can't sort out a really tough disease challenge with few spontaneous recoveries from an ineffective antibiotic. But I'm the veteran of multiple disease outbreaks in food animal populations, feedlot cattle especially, where we changed nothing and the outbreak resolved, and we just focused harder and harder on finding the cases, our prevention, everything else we could do. But if we would have changed an antibiotic, we may have left with the impression that what needed to happen was we changed the antibiotic, and that was responsible for it. And sometimes the antibiotic is, I don't know what else to do. And I read histories of sulfas first being introduced for human use, and they were handing them out for flus and colds, even though being told that it wasn't effective against those. So there's a little bit of human behavior. I understated that. There's a lot of human behavior involved in this. And antibiotic resistance selection, we just covered that, antibiotic exposure and the exposed bacterial population. The first failure in stewardship is failure to prevent the infection. And that's not always possible. But I always look at that when we have bacterial infections, we weren't able to prevent it. And there can be a variety of things that could have helped, but not always possible. The second failure is failure to appropriately treat the infection. And that could be due to resistance. It could be due to inadequate dosing. And I think on the human side, as well as the veterinary side, we're looking back on our 7, 10, and 14-day courses of antibiotic therapy and realizing that in many, many cases, we have no justification for that other than it's 1 or 2 weeks, or what I call the metric week, 10 days. And that's how we settled on those durations. There are multiple studies out there comparing longer and shorter durations. I found 8 on the human side when looking at trying to inform our duration of therapy better, or when to make success failure definitions in cattle with pneumonia. And in those 8 studies, all of them had a shorter or longer duration randomly assigned in a population of different antibiotics for community acquired pneumonia. And while not powered to say they were the same, in all 8 studies, they were unable to show a difference in outcome between the shorter and the longer treatment duration. And some of them pretty well powered, pretty large studies. So failure to reject the null hypothesis doesn't necessarily mean they're the same, but in 8 studies on the human side, they failed to show that a longer duration of therapy increased treatment outcome compared to a shorter one. And personally, I think that going back and revisiting our treatment regimens for drugs like amoxicillin, ampicillin, the doxycycline, minocycline, potentiated sulfas, some of these staples of therapy would give us as much or more bang for the buck as coming up with a new antibiotic. And the ultimate antibiotic failure is bacterial population exposure without achieving the desired effect. That can be because we don't have the actual disease there we thought we did, or we're using an antimicrobial inadequately dosed, or we're using one that is ineffective just due to constitutive resistance or has become resistant. And the veterinary feed directive, which had the new labels go into effect January 1, 2017, resulted in a whole lot of conversations between veterinarians and their clients about authorizing the use of in-feed antimicrobials, and it also took our water antimicrobials to prescription, and those also brought about a lot of conversations from what was previously available and was used over the counter to being under veterinary control. And we'll look at what happened by doing that. So I think all of our futures are going to involve bacterial population-based phenotypic and genotypic information related to both displayed in vitro resistance and also resistance gene presence. And we understand the challenge that it's not always consistent between genes and their expression, but working on that. So Fleming warned us in 1945 about antibiotic resistance in his Nobel speech along with Florey. So how long does it take for that to happen? This is a really interesting chart that I found from a Mayo Clinic proceedings in 2012, and it so nicely demonstrates it. If you look at penicillin, ampicillin, third-generation cephalosporins, and carbapenems, from their first clinical use in people to the first documented resistance to them in the literature, you're looking at 4 to 7 years on the human side. between when they first documented resistance and when those antibiotics were first put out and generally used in the population. That doesn't mean the resistance was ubiquitous, but it does mean that we were identifying it for the first time. So I classify antibiotics bacteria as taking the possum approach to life, is that they don't live in a very intellectual existence, but they have a whole lot of offspring. So I mentioned Mannheimia hemolytica, and I want to talk about something that illustrates a change we're seeing in diagnostic labs, and it also illustrates the challenge with interpreting basically a compilation of diagnostic laboratory data and exactly what we take from it. But MHEME, here's an example of this primary pathogen in bovine respiratory disease, and here's one lighting up quite a few R's across it, and this was from a case that was submitted here that I participated in working up. And this gentleman had purchased 100 head of calves on a truckload, treated 25, and 12 of those 25 had died, and that was essentially a 50% case fatality rate, which is way out of the norm for treated cattle. And this was a multi-drug resistant Mannheimia hemolytica, especially to the macrolides, which is what he'd used for treatment more than once enough. So Lubers and Hanslechek here at K-State published this report in 2013, I guess, actually, when it was published, about 3 years of MHEME isolates from the Kansas State Diagnostic Laboratory. And this is mirrored in many other diagnostic labs. And what it shows is things like this for enrofloxacin, a fluoroquinolone, approved for use in treating bovine respiratory disease. And you go on the right from 2008 through 2016, and from the left, less than or equal to 0.12 micrograms per mil, that's our lowest dilution tested. We test up to 2, which is the resistant break point, and anything not inhibited at 2 would be reported out as greater than 2. If you look back in the early 2000s, almost everything was stacked to the left for that wild type population. We saw this bloom in 08 to 10 at 0.5, and then things flipped over, and basically in the lab we were getting ones that are around 60% of the isolates were resistant to those. And that's characteristic of the fluoroquinolones with a 2-step mutation path to resistance. That 0.5 represents our population showing that first low-level mutation, and then that second high-level mutation bumps us over there to the right. Fluorphenicol, we also saw a bloom about 2008, starting peaking in 2012. It's backed off a little. In Oxytet, we're at about 70 to 80% that are resistant from the MHEME isolates coming in over the years. Now, these are a population of bacteria from cattle for which samples were submitted to the diagnostic lab, and in the vast majority of cases, they were mortalities who had had necropsies done. There may be a few that died untreated that weren't detected that were sent in. So these, by and large, were ones that had been exposed to antibiotics, and we'll look at another study that considers that later. Penicillin for MHEME, high number of isolates clear over there, clear to the right. Here's tilmycosin, which is a macrolide. It's not used in human medicine. It's one we use for bovine respiratory disease. And back at 2000, 2001, you wouldn't have seen hardly any of these isolates that were to the right. And then in 2006, 2005, we started to see a movement to the right. And then in that 10, 11, 12 time period, we saw quite a little bit of movement. And this drug had been used since 1992, and at one time held probably well over 50% of the bovine respiratory disease market in cattle. Now, if we look at tulathromycin, another macrolide, another class that was released in 2006, you see that resistance quickly mirrored that of tilmycosin in this population of isolates from this population of cattle. This isn't across all cattle by any means, but what you see is we have that quick bloom there, and about 85% of the isolates that are resistant to tulathromycin by the CLSI breakpoints are also resistant to tilmycosin and vice versa. So this illustrates how many of those are multi-drug resistant, and almost all of those isolates displaying resistance are the same ones. And this is ceftiofur usually shows susceptible that the integrative conjugative element does not contain a resistance gene to third generation cephalosporins. But what they've discovered and is well described now is an integrative conjugative element, which can pass amongst our three major respiratory disease pathogens and also E. coli in the laboratory. It encodes for these. It does not encode on the ICE for fluoroquinolone resistance, but in our experience in our laboratory, it seems to be present with it. We've had that described on the human side. They call those suitcase genes. They tend to ride along, but they're not actually on the identified element. So in response to those findings, the folks at Iowa State University did a study where they looked at the isolates and if they had indicated how many times they had been treated. And we're going to focus on Mannheimia hemolytica down here. And they had 80 isolates that had not been treated, 121 treated once, 101 treated twice, 45 treated 3+, and 193 unknown. And this is from Magstead et al. From Iowa State. This is a reproduction of one of their figures. And you can see across all these antibiotics, the left bar is not treated at all, then treated once, twice, 3 times. Oh, excuse me, it's unknown on the left, then none, 1, 2, and 3+ treatments. And you can see across all these drugs, the more times they were treated, the more likely they were to be displaying these multi-drug resistant isolates of Mannheimia hemolytica. And so you would opine that there's a selection pressure there based on how many times they were treated before they ended up there. So an example of drug selection pressure on those being present in those animals. So the last thing I want to close with, so we have some time for questions if there are any, is that our domestic sales and distribution reports happen every year from ADUFA, Animal Drug User Fee Act mandated data collection of sales. 2017 data there, you can see the drop from 2016 and 15. Whether or not that was entirely due to the Veterinary Feed Directive and prescription requirements for water, medically important antibiotics, VFD for feed, medically important antibiotics went into effect. I can't say what percent of that is. All you can do is note that there's a temporal association with that going into effect. And you can see cattle, swine, chicken, turkey, others, 35, 47, an average, a mean of about 33% reduction in use during those time periods. So that is, again, temporally associated with the increased oversight of veterinarians on antimicrobial use. And prior to that, including water and feed, about 95% or so of medically important antibiotic sales by weight, which is an imperfect measure, but by weight, were over the counter. And you can see that one of our primary uses there is the tetracyclines, and that has gone down dramatically, and they are our highest use antimicrobial group. The ionophores are non-medically important there, and they stay fairly steady. And one of the things I like to point out here is the cephalosporins and fluoroquinolones, some of our most highly medically important, are also our lowest use, lowest sales. They have no feed or water applications. And cephalosporins in food animals may only be used off-label for indication under a veterinarian's approval without the ability to use an off-label regimen, and fluoroquinolones absolutely no legal off-label use. Right now, we're in the first years of the 5-year plan from the FDA, which includes very close scrutiny of veterinary feed directive antimicrobials, which would have unspecified durations of use, and they have received all of the proposals which they requested for doing research to help identify information which could apply to setting more defined durations. They're also going to focus more on evaluating antimicrobial stewardship and companion animal practice. They're going to support stewardship, innovation, and efforts both nationally and internationally, and you can access that. And one last plug for the Presidential Advisory Council on Combating Antibiotic-Resistant Bacteria, or PACCARB. I've had the pleasure of serving on there as a voting member, and it's been a great educational process for me, and has really widened my view of how similar we are between human and veterinary medicine. They have a website which has archived video of all of the public meetings, and in those there are some fascinating panels. A lot of really talented and well-educated, knowledgeable people have come to talk to us, talked about their initiatives. One of my favorite was the one focusing on environmental resistance, and we had people talking to us from everything from sewage treatment to wildlands to all kinds of things. Those are all available on there. You can scroll down through and look at the different agendas from the meetings, and then you can access those and actually listen to the presentations and the council interaction with the panels. A lot of really good stuff on there for anyone who's got an interest in antimicrobial resistance. The National Action Plan to Combat Antibiotic-Resistant Bacteria, or CARB, and the activities of that council. A lot can be learned from that. So that's my quick 50,000-foot run through of what I think resistance means, what I think stewardship means, the place of veterinarians in driving stewardship in relation to their food animal clients, and the complexity of that, and the complexity of the systems within which veterinarians work with their clients, and also a little bit about antibiotic use trends and how we try to monitor some of those things. So Nicole and Amanda, and by the way, Amanda's one of the ones we've had come talk to us at PACCARB. If there's time for a question or two, well, I'd be happy to take those.
Great. Thank you so much for your presentation. Are there any questions? I can start with one. So one of the greatest challenges that we have in veterinary medicine from the standpoint of stewardship, you mentioned, and that's the challenge that we have with diagnostics and how we are able to conduct diagnostics both in clinic-based medicine and on the farm, given the high cost and some of the sort of historical precedents that have been set with regard to treating first and diagnosing later. So how do you think we as a profession might deal with some of the challenges that lack of diagnostics brings to our ability to drive judicious use and stewardship programs?
Well, you have to demonstrate the value to the clients, and I really think that the primary movers in this are going to be, for food animal, are going to be supply chains, retailers, supermarkets, quick service restaurants, all types of restaurants that are looking to demonstrate their engagement in stewardship in order to, meet customer demands, or just the right thing to do. And that's going to apply a pressure where perhaps there needs to be a little more documentation of why we're doing things. In some countries, other countries, for example, to use some of the most critically medically important antibiotics, they have to have culture and susceptibility testing results, and then they're only able to leave limited supplies. And there's a lot of models around the world. Here in the United States, we, as veterinarians, tend to chafe a little bit at that type of oversight and control, but we're looking at state legislative initiatives. We're looking at sales initiatives, again, on the part of supply chains at all different levels. And I think those are going to bring an additional focus on that, which will probably let veterinarians put that together along with demonstrating the utility of those, and hopefully we could have a little bit more of that. And In the case of that Mannheimia hemolytica, I showed, man, some of those isolates, if it's resistant one to one, it's resistant to a lot of them. So that can be pretty scary. But we're in agreement. That's one of our biggest challenges.
Any other questions for Dr. Apley?
It looks like we do have a question, Amanda, and I'm having trouble getting it to show up. Down in the Q&A, if you can see it. Cursor isn't working very well.
Okay, yes, I do see it.
Thank you.
Cephalosporin is a novel siderophore cephalosporin, which is due to come out in the near future for human use. How do you think this will affect regulation of ionophores in animal use, since currently they are listed as not medically important? Will that change?
Yeah, the ionophores are one of the things we really would like to see stay to be able to use. And I think to evaluate that, we would have to see if there is any documented cross-resistant selection or anything that's happening in food animals. And I think in all these cases, the easy answer, it's easy to say, but hard to gather resources to do, is I'd like to see us really look at, after all these years of the ionophore use, if we've actually selected for anything. And my interpretation of the data for co-selection to other organisms, or even to ionophores themselves, is that I don't really see any indication of the organisms that we target with the ionophores or co-selection, that there's no evidence that I've found that would support that they are selecting for resistance. But we'd need to look at that, I guess.
Great, thanks. And then I guess I just have one other question. From what you've heard with regard to FDA's approach, and also other federal agencies that are involved, has there been any discussion about doing a better job of formalizing some food labels with regard to antibiotic use?
Well, so those food labels would be on the USDA side. And of course, we have organic. And as I understand it, someone may correct me on here, but natural is still about, the official natural label is still about the preparation procedures for the food once harvested from the animal, and does not apply to the actual animal itself. And we see there's process verified programs, such as the one by School Food Focus for poultry raised with chicken raised with responsible use of antibiotics, that is a USDA PVP and audited by the USDA, where they have certain claims that the USDA audits are in there. Otherwise, some people have their own that they use, and you have to be very careful about looking at what they do. But the PVP is where I've seen some happening. You're also going to see continued advancement of production systems that have their SOPs that they audit and will document that they're following those. So there's movement on a lot of different ones. I'm not able to speak on where any further clarification of natural as to procedures used to raise the animals is. I'm unfortunately not up on the latest on that.
Great. Thank you. Any other questions before we finish up here? All right. Well, thanks to everyone for their attention today. All of these webinars in the series will be archived online, and we'll provide attendees with the website link and promote the use of the webinars widely for use in your trainings and just general education opportunities. On the next webinar, we will be joined by Irene Bueno from University of Minnesota and Joshua Berman from Minnesota Pollution Control Agency, who will speak on the environment, AMR and the environment. What do we know, and what is the veterinary role? The session will be held on July 16th at noon Central Time. Thank you so much, everyone, and have a great day.
Thank you, Dr. Apley.
Thank you for having me.